Yes, I cut you off before,
no,
sorry.
you didn't. I appreciate the opportunity to ask you. First of all, I do want to say you had a very interesting slide there with the cost of various countries and what they spend on individuals. And I'm disappointed that it's not in any of this information I have, because I really would love to have a copy of that.
Is it not in the Little League?
I didn't see it. And the question that I did have was, you had a pie that showed that 17% of our gross national product was spent on health care.
Yes.
What is a healthy percentage? What's our target? Because I don't know.
Well, it depends on who you ask. Our target is down. That's as general an answer as I can give you. I think people would probably like to be able to cut about 5%. But the problem, as soon as you begin to talk about how much you're going to use as a goal to cut, people get nervous. Well, they get thinking, you know, there goes my good health care. They're going to take away some of my benefits.
Not really, because if you're presenting some data, this is what we're doing now.
Right.
And you're implementing a program to cut your costs, you should have a target or a goal or know where you want to go. Right.
Well, I have no doubt that economists and health policy people, although they won't agree on where they want to go, but they surely have goals in mind. I think the idea here, though, is we want to go as low as we can reasonably go without harming our healthcare system. But for example, if you think about the coordinated care and trying to minimize unnecessary repetition of stuff, I don't know about you, but frequently, if I am sent from one doctor to another, they seem to redo all the same tests. Oh, go get your blood work done, and we're going to do x-rays. And you want to say, well, you know, that information is someplace. I don't have it, but somebody has it. That's going to cut down to some extent on the cost. But you have to be able to reassure people, I think, ahead of time that what you're trying to do to cut cost is in their best interest. You're not trying to take away from them anything that could be helpful to them. And I think this is one of the concerns about the health care law, and one of the reasons these wild rumors go around. And here's one of them. I get this question almost every time I give the talk. What about that committee of 15? You heard about it? IPAB, Independent Payment Advisory Board. Anyway, what about that? And the stories that go around about it are the death panel all over again. You must have heard some of this. Oh, the president is appointing these 15 people, and they're going to decide if Granny, who's 86 and needs a knee replacement, it's too expensive, she's too old, we're not going to do it. That's the crazy story that goes around, things of that sort, that their job is to decide for us old folks how much we're worth. Can we really afford to do such and such a surgery on her? Isn't she too old? It's not worth it, too expensive. That sheer nonsense. That 15-person board has nothing to do with anything like that. There's nothing in the law that does. Well, what do? They are appointed by the president, that's true, with input from the majority and minority leaders in the Senate and the House, and there's plenty of talk about who's going to be on it. It's going to be economists, health policy people, doctors. It specifies representatives of the elderly, the head of Health and Human Services, the head of Medicaid and Medicare. Those are ex officio on it. What's their job? Just one thing they have to do, and it has nothing to do with you and me and our health. Their job is to keep track of the increasing cost of Medicare. Now, they project how the cost is likely to go up. For example, baby boomers are coming in. They have to know the cost is going to be going up a certain percentage. The job of this committee is to watch that and be sure it doesn't begin to go out of control. And as soon as it shows signs of going up beyond where it can, where we can afford it, Their job is to make a proposal to Congress and the President about how to cut that spiraling out of control cost. How might they do that? It doesn't have anything to do with Granny and her knee or her heart or anything else. It has to do with things like we need to cut more subsidies from the private insurance companies. We need to cut payments further to hospitals where people are coming out with infections that they picked up in the hospital. That's a quality difficulty in those hospitals. We have to cut payments to hospitals where there's an inordinately large number of people being readmitted within 30 days of having been discharged. There's something wrong with how the hospital is taking care of those people. We have to cut payments to doctors where the quality of care is below average. That's what they're talking about. It's all about money. And it has nothing to do with whether or not you and I are going to get the health care benefits that we think we deserve. So the next time you hear that rumor, tell people what the truth is, that that's just sheer nonsense. It could not be further from the truth. And it's just a remnant of that death penalty, death panel nonsense. That somehow this law is setting up some little group of people who's going to decide who can live and who dies. Absolutely not. There isn't anything in the law that even approaches it. Yes?
There's another myth on the internet where I think it's 3.8% for real estate taxes. Everybody selling their house is going to have to pay an increased tax.
Good.
I know it's false. But
It is false. Yes, there's another rumor going around. I've gotten the email several times. I've even written a letter to the editor about it. The rumor is this. In the healthcare law, there's a 3.8% tax. And when you sell your home, say for $100,000, 3.8 of that is going to the federal government. This is nonsense. The 3.8% tax is in the law, and it's a tax on unearned income, so dividends and interest and anything where money earns you something. You didn't work for it, but money does something good for you. That's unearned income, and there will be a 3.8% tax on that, and that tax in the law is referred to as a contribution, mandated contribution to Medicare. Now come back to the house. Would you have any unearned income on the house? Well, you might. Suppose the house sells for $100,000, and suppose you only paid $95,000 for it. Well, $5,000 of that is essentially unearned income under some description. So the tax is 3.8% on $5,000, which is what? A couple of $100. We're not talking about $3,800 as the rumor would have it. But of course, if you have done a lot to improve the house, that might be perfectly earned income. You've invested a lot in the house, and that's why the price went up. But on unearned, that's just, you know, your investments.
So this is in addition to your capital gains?
It's related to capital gains.
But is it in addition to?
Yeah, it's anything that is like capital gains. That is unearned income.
But
it's money that earns money.
3.8% in addition to the 15%?
Yeah, I think so.
Okay.
I think that's right. Yeah.
But isn't
That's
it,
your wonderfully generous contribution to Medicare.
That's a contribution.
That's a nice line. It's right in the law, your contribution.
isn't it for earners salaried or
Oh, yes, good.
people
Thank you.
over $250,000 a year?
Yes, thank you. Yes. 200,000 for an individual, 250 for a couple. That's right. Good, thank you. Yes, so
That's
almost
your home
any.
sale. Yeah.
I
Yeah,
think it's 3.8.
that's right. Almost any financial penalty-looking things they're means tested. You're making 200,000 if you're an individual, or 250 if you're a couple, before that becomes relevant at all to you. Right? None of this is geared toward people who are in the lower income bracket.
Okay. One more question.
Yes.
The age 26, you say,
Yes.
for a student, do they have to be a student?
No, no.
Or they can just reside in the home?
No, none of that is relevant. They don't have to stay at home or not. They can be married or not. They can be a student or not.
Okay.
Makes no difference. I should clarify that if they are married, say wife and children don't get on mom and dad's policy. Just the child.
Just the child,
Yes.
okay.
But there are very few restrictions on that.
Okay.
They can be home or in their own apartment. They can own their own home, whatever. Okay. What else? Yes.
Today, you often hear that doctors order extra tests because they're concerned about malpractice.
Yes.
Right? Is there anything in the law that
Yes.
affects that?
Yes, there is. Malpractice is a really difficult issue, right? It's doctors and lawyers, and one or the other wins, right? If it goes to malpractice, the doctor frequently loses, and he's paying very high premiums, and the lawyers win. And if malpractice suits are cut in some way, the lawyers lose, and the doctors win. What the law asks is that each state set up either a commission to study the issue, including doctors and lawyers, to see if they can come to some reasonable compromise, or set up experimental situations. Try a few things and see if they're working better than what we're doing. So the only thing in the law is, we know this is a tough question. We don't have a simple answer. The doctors and the lawyers are going to have to come up with something that they can both agree on. And we don't have it yet. Okay? Yes.
Professor Dickie, I have two questions.
Sure.
I want to go back to the chart again that had all the different countries on there.
Yeah, I'm sorry, I never noticed that that's not.
What is Turkey and Japan doing that we're not doing?
Well, of course, Turkey is not doing all that well. They're 5 years worse than we are.
But their cost is down.
Yeah, well, the cost is down. Japan, I have wondered about that. Among other things, you have to think, I would suppose, about their diet. A great deal of fish, great deal of rice. Because if you look around, many of those Asian people are quite slender, very active. So I'm inclined to think that one of the things that they are doing well has to do with nutrition and exercise. And these are two of the things that are very big in the law. There's a good deal of talk in the law, even among the preventive services. There's talk in there about getting counseling about nutrition. This would be geared toward people who might be good candidates for diabetes because of weight. Getting counseling on exercise. This, especially for us as we get older, to keep the brain functioning well. So I'm inclined to think that lifestyle must have a good deal to do with getting a higher average life expectancy. And the medical care, I don't know Japan's medical care. It may be much better than ours. I do know, I've met at a number of these talks, I've met people from England, France, Canada, who will come up afterward and rave about their healthcare system. In spite of all the nasty things we say about it, they rave about it, and they claim it works very, very well for them. So there are a lot of factors, I guess.
The second part of my question was, and you kind of touched on it, with obesity.
Yes.
And you mentioned that a person that smokes, their premium would be higher.
Yes.
Is that going to be, I mean, is there anything in the law about obesity? Because that is so huge in our country.
Yes. A couple of things, and also about smoking. Advice? Yes. Sure. Sure. Have we gone 80 minutes? Wow. He's putting in a new tape and asked me to wait. Sure.
Just take a second.
Okay.
Action.
Action. Here we go. There is a good deal in the law about counseling of all sorts. Counseling on nutrition and exercise for obesity. Counseling on how to stop smoking. Counseling on how to break an addiction. And I saw just recently for Medicare in particular, and this may be a new, I don't know if it's a new preventive service, but counseling on depression, which us older folks are really subject to depression, especially if you've lost a spouse or a family member or whatnot. So there's a good deal in the law about various kinds of counseling that would, in a sense, be preventive, if you will. I mean, there are efforts to get people into better physical shape and better psychological shape. I might add, by the way, the law specifies 10 what it calls essential health benefits. And 8 of those you would recognize right away. I think they're fairly standard. But 2 of the newer ones are maternity care. That has to be available. You shouldn't have to buy a special rider to get maternity care. It should be available on your policy. But the 10th one is mental health, which insurance companies, I think, are still a little bit skittish about because it's meant to take care of standard mental health problems, but also behavioral problems. And once you say behavioral problems, that gets quite large in the insurance company's mind, I think. But there's, yeah, the emphasis throughout the law is very broad. That is, the understanding of health is very broad. It's emotional, psychological, physical health as all being important. I skipped a slide. I'm just realizing it now as I talk, and I don't know how I did that, but there's a slide in there about the impact of the law on women. And a couple of quick things there. One is, come 2014, insurance companies can no longer charge us double and triple the premiums they have charged our male counterparts. I never knew they did.
For what?
For our health insurance. Premiums for health insurance. Yeah. So that will be illegal in 2014. But the other thing is the preventive services available to women, they're quite broad. This is not simply your flu shot. There are preventive services for HIV screening and counseling. There are preventive services for I never remember the full name of the virus that can cause cervical cancer. Papilloma virus. There's screening and counseling for that. Screening and counseling for domestic abuse. Counseling and supplies for breastfeeding for the young mother. Very broad. Unlike earlier health care law, women's health has been taken very, very seriously in this one. There is, in fact, an Assistant Secretary of Homeland Services, Health and Human Services, just for women's health. Yes?
Back in one of the earlier slides, there was a discussion about the cost improvement, that is, the reduction in deficit that we're likely to experience with the implementation. Do you have any idea how that was calculated?
Well, yes and no. I read both of those reports from the Congressional Budget Office. But, I mean, when you finish a report of, maybe 50 pages that is filled with very technical detail, I'm not an economist, so I certainly can't report on exactly what he did and how he, well, actually, I shouldn't say he. There are 250 people that work in that office and work on those documents. But I'm certainly not in a position to give you any kind of detailed account of exactly what figures they were using and what equations. But I'm inclined to figure that he probably knows a good deal more about it than I do.
Right. I guess I'm wondering whether or not there are assumptions in there about the implementation of the information technology which you referenced earlier and the impact that.
Right. Well, the law, in much of the law, not all of it, but in much of the law, money is specified. It's set aside. It's mandated. I think maybe 3/4. I could be off on that. But in the law itself, in many places, it specifies how much money is being set aside for that. And the money for the information technology, the government has been sending substantial amounts of money to various healthcare providers explicitly for that, explicitly to get medical records on computer and to get the kind of software that will make that information accessible and shareable and secure. So many aspects of the law, the money is right there in the law specified. So I don't think that every aspect was, but I think that the Congressional Budget Office probably had a fair amount of actual financial data to go on. Okay. What else? No?
I have one question.
Yes.
It may sound stupid. but-
No, questions never sound stupid.
Okay, so basically, the healthcare is law. They are not going to provide any of the services you're talking about. It's only that they're going to mandate that insurance companies have to do this. Is that correct? Other than Medicare,
What kind of services do you have in mind?
any kind of medical service. I mean, it's not going to be an insurance program. It's going to be.
That's right. The law itself is not
It's just
insurance.
okay. It's just going to be. Yeah.
Yes.
Not that okay.
A couple of things, though. When people tell you that the law is a federal takeover of healthcare, that's simply false because the insurance companies play a very significant role in this law. Very significant. I might add, by the way, that the law also mandates that in 2014, every member of Congress, Senate and House, and their staffs will get their health insurance on the health insurance exchanges, like everybody else. This may be one reason for a little opposition to the law in the Congress, I don't know, but yeah. And that's another email that was going around saying that they were not, that they had exempted themselves. No, it's in the law. It's in the law. They have not exempted themselves. Yes?
Can you in any way contrast this law with what was enacted in Massachusetts some years ago?
I certainly can't give you any details on that. I can tell you that, just last week, I think it was, I had a group that included 2 people from Massachusetts who both said the law was a wonderful success in Massachusetts. They thought it was terrific, and it seemed to them clear that this law was modeled on that. There was an individual mandate in Massachusetts. They have high 90% of their people enrolled in healthcare insurance. They hit financial problems, and they made a few cuts here and there, and it seems to be working again pretty well. But I don't know the details of, as they say, Romney care. Except to hear people from Massachusetts say, contrary to rumors you've heard, people there like it very well. Anything else? Yes?
You talked about the bundled payment idea. What happens if the different healthcare professionals don't agree on the plan of action?
Right. Well, and they have to. That's true. That would be an assumption, that the team somehow has to come to an agreement. Now, I have read some places where the primary care physician, your medical home person, is referred to as the quarterback. Maybe the quarterback gets to decide how it's going to go. I don't know. That would depend a great deal on the quality of that doctor, right? And that doctor working with specialists where he or she may not be. So I'm sure there'll be some disagreement and some give and take, and a hope that it will all work out. I don't know. I don't know who has that final word to say this is the way it's going to be. But I would suspect that the primary care physician, there is, by the way, in the law, a good deal of talk about medical education. and about the need that we will have for many more primary care physicians, and a mandate to increase their payment, because by and large, family doctor, primary care doctor frequently are paid less than a specialist, and so it mandates that they be paid more than they have been paid. But the idea of a coordinated team, you begin to hear more and more about it. I should say, at the larger scale, especially for Medicare, this started with Medicare, and I don't know if it has expanded outside of that yet. They call them accountable care organizations, ACOs. And these are larger groups of healthcare providers. Sometimes it's several hospitals that come together as accountable care providers. And they propose to the Health and Human Services what they mean to do and how they mean to organize it, so on and so forth. And they need to be approved at the federal level as accountable care organizations. But then that whole large thing becomes a sort of large teamwork, working cooperatively, coordinated care, taking care of the people they take care of. Anything else? There are no dumb questions. That's a very important thing for people to know. There are no dumb questions. Yes?
When you were talking about the exchanges, it made me think of currently if you would go to the Medicare website and use the tool that's online. You put in your zip code, you put in what prescriptions you take, and then it does a comparison of programs that are available in your area and the cost. And what's surprising, what I learned in using that tool, is that all non-insurance companies don't classify medications the same. It's not standard. One company may classify your blood pressure medication as a tier 1, which is the cheapest rate at which you're charged. Another insurance company may classify it as a tier 3. So until you utilize that tool and you look at the numbers and the data, and you're able to compare the company that charges you no premium, no deductible, no minimum, might be the most expensive program for you to belong to if you can't do that kind of a comparison. So the exchanges, I feel, are very interesting. And I apologize, I interrupted you. I didn't understand that you jumped from Medicare to private when I was looking at that slide.
Sure.
Because I know that's currently on their website, and that's how they're allowing you to compare programs now.
Right. Well, and the ability to go online and get information about insurance companies is there. It isn't set up yet as an exchange for the state, but if you go on, for example, healthcare.gov, at the very top of the home page, there are 4, maybe 5 little rectangles, colored rectangles, each with a topic. And one of those topics is insurance. And you click on that and it will begin to take you through the sorts of insurance that might be available for you. Generally, those programs will ask for some information about you, where you live, how old you are, and so on and so forth, and then can begin to give you leads into the type of insurance that might be useful for you, might be affordable. But the exchanges, I think, are going to be in much greater detail and much greater transparency once they're up. And the idea, of course, is for the insurance companies to compete for your business and bring those premiums down. Another item I should mention that isn't in the slides, but about insurance premiums, the 80-20 rule, does that ring any bells? Actually, the law has an 85-15 and an 80-20 rule, but here's how it goes. Insurance companies are required by law to spend a minimum of 80% of the premiums they receive, healthcare premiums, on actual health care, not on any administrative costs, not on salaries, not on bonuses, not on, junkets to Hawaii for the staff or any of that. It has to be exclusively on health care. And if an insurance company, and they have to report exactly how much they get in premiums and where they're spending their money, if an insurance company spends less than 80% of its premiums on you, on your health, they have to send you a rebate, a check. This past August 1st was the first time those checks had to go out, and over $1 billion was rebated to people around the country. People here in Florida, over 1 million people here in Florida got rebates. You got one?
No, I heard about it.
You heard about it, yeah.
Nobody has sent me any money for a long time.
Me either. The larger companies, it's supposed to be 85% of the premiums get spent on health care. Now, in the past, that means they're only left with 15% for overhead, for administrative costs. In the past, many insurance companies have been spending 25 and 35% on administrative costs and only 65 on your health. So this is a real push, and my thought is that this may possibly encourage them to see that perhaps they could lower some of their premiums because they're having to rebate them as it is. Let's see. Anything? No? Well, thank you so much for coming, spending a beautiful afternoon in here.